Thank you for watching this program tonight with the best physicians of the region. My name is Dr. Luis Munoz, and I'm the president of the El Paso County Medical Society. It is our hope that you will find this program informative and interesting. We at the El Paso County Medical Society invest in community education with our programs. I hope you will find this program very informative, with great medical advices and great medical information. Thank you again for watching this program tonight, and have a great night.
With the advancements in medicine and simply taking care of ourselves a little bit better, we are all living just a bit longer. And isn't that great news? There are, however, some physical complications with aging and sometimes mental complications, which all can be a bit emotional and difficult to talk about. This program this evening is called Mind Matters, a conversation about dementia and the mental health of our aging family members. We'll talk about the first stages of dementia, of diagnosis, and treatment options that exist here in El Paso. This program is underwritten by the University Medical Center, the Geriatrics Department, and a big thank you to the El Paso County Medical Society for bringing the show to you each month. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. We're talking this evening about Mind Matters, a conversation about dementia. And it's not just about misplacing your keys or putting something in the refrigerator that you need to take out the door. This is real issues with people who are aging. We have two geriatricians with us this evening. We have Dr. Jose Luis Aguirre, who is with us this evening, and thank you for being here. Again, you're a geriatrician. We'll talk about what that specialty is in a moment. And then we have Emmanuel Enriquez, who is also a geriatrician. So when I say that, obviously the word geriatrics means geriatrics of older age, and maybe we can define too what older age is. I think that today's 60 was yesterday's 40, today's 90 was yesterday's 65, I'm not sure. But in general, if you're going to explain what the discipline of a geriatrician is, Dr. Aguirre, how would you explain what that is?
The easiest way to think about it is, everybody knows pediatrics, right? Mm-hmm. Pediatrics is the care of children and teenagers up to the age of 18. Geriatrics is not that new. It has been around for at least 50 years. And geriatrics really is the care of older adults. It's defined arbitrarily with the age of 65. I think, as you pointed out, many people think that the 60 is the new 40 and perhaps 80 is the new 60. And that, to a certain extent, may be true with the advancements in medicine and what we better understand about how to take better care of ourselves. And so, at least here in El Paso, where we're still trying to establish a geriatric medicine culture, 65 and up is really the population that we take care of. Okay. And the types of topics that we try to do, it's confusing because doctors say, "You're a geriatrician, what does that mean?" Mm-hmm. Then we have our patients. "Oh, they told me you're a geriatric doctor. Well, what does that mean?"
Right. Exactly.
So we're kind of a hybrid specialty in the sense that we are a primary care physician for older adults, arbitrarily 65 and up, but we're also specialists to other primary care physicians for a host of different issues. So many times we may co-manage a patient with their primary care provider, where we're doing a review of medications, maybe having sensitive talks that we have more experience doing, like advanced care planning in terms of having your advanced directives, your medical power of attorney, do not resuscitate forms, these types of difficult conversations, but that should be done early. We also help in figuring out why people are falling, fall assessments. Polypharmacy, are they on the right medications, or are they on the medications that may potentially cause them harm? And so in that sense, we are both PCP, primary care physicians, and specialists. Mm. And so we are able to help the population in that sense. There are only about a little over 7,000 geriatricians in the entire country. In the city of El Paso, board certified fellowship trained. There's only 10 of us with Dr. Enriquez, which recently joined us. UMC has 3. And so there's not enough of us, certainly, to take care of the entire geriatric population. But because of our expertise and our specialty, we're able to provide additional help or support to the primary care physicians in our city.
Well, I think that we're all inching more and more to that area. So I'm glad that this is something that is expanding, especially here in El Paso. Dr. Enriquez, so Dr. Aguirre kind of explained what geriatricians do. What is it, if you can kind of explain, like your routine all day, every day as a geriatrician? How does it differ from other doctors? Like, do you have rounds that you do every day? Do you have appointments that come in every day? In general, how does a normal day for you go?
Well, like at the clinic, I mean, it's pretty similar to like a sort of like a regular PCP visit, but it depends obviously on what sort of aspects going to be covered. If you're doing just like your primary care, visit, it's like pretty much the same time allotted. But if you're doing like a annual exam or you're doing like a memory assessment, I think things are a little more different than what you might do as just a PCP. And then like there's like other aspects to consider as well, like in the intake when the patients come in, like things to ask about, like the fall risk, the depression risk, the all these issues that are very specific to the geriatric population. I mean, I'm pretty sure everybody does it, but like we try to be very, like the medication is, review by both the DMA and the provider. So like we kind of like our outlook's a little different, kind of like more focused on what the geriatric population or elderly population might be needing. And like with that in mind, like maybe the intake's a little different, the things that we look for are a little different. But yeah, and like it depends. Like if it's just like kind of like your follow-up visit, it's pretty similar with that kind of like mindset of taking care of different aspects that affect our elderly population. And other visits are a little more like, a little more time, like the memory assessment and other things that you deal as a provider for geriatrics.
And so that is a great transition into what we really are here for this evening is dementia. And I feel that through the media and through movies and television shows, the word dementia is just kind of thrown around. It's like, oh, well, they've got dementia. Oh, they've got Alzheimer's. Oh, it's early this, it's early that. So I'd kind of like to set the record straight, if we could, this evening. And Dr. Aguirre, if there is a true definition of dementia, when people use the word as a medical professional, what does the word mean?
It is interesting that you come up with the word dementia specifically because I was not in tune with this before. And so I became a geriatrician and started treating people from all different types of backgrounds. I think I become a little more culturally sensitive to it. The word dementia really means loss of the mind or out of their mind.
Oh,
So
interesting.
in some cultures, saying that you're demented means that you have lost your mind.
Yeah, and that's so good that you said that, because I feel that some people say, oh, they're demented, which has a whole different connotation. There's the definition of it,
And so I think
but there's the culturally used word.
And so I think the word itself does mean like losing one's mind. That is the literal definition of it. However, the way that we use it is when there is a loss of memory beyond what is considered normal.
Okay, I like that. The loss of memory beyond what is considered normal for any given age,
Yes.
we say? Okay, great. So if you're looking at it that way, and Dr. Enriquez, if I can bring this on to you, and feel free to both kind of throw it in there. So when we say dementia or loss of memory beyond what is normal, there are different types, right? I think we all think about Alzheimer's. We all think about sometimes Parkinson's it's part of what happens with Parkinson's. But in general, what are the different types of dementia that you deal with?
So yeah, like Dr. Aguirre was saying, like the dementia component is like kind of like the loss of like that cognitive abilities of a person that's not normal, right? So like I had one of my professors that described the dementia as well as like a brain failure, right? The brain's not working as it's supposed to be, and there's a host of issues that could be causing that, right? So that's how we kind of like classify different types of dementia. The most common one is Alzheimer's dementia, the one that's more prevalent, the most population that have it. We also have things called vascular dementia, We also have Lewy body
So
dementia.
go back. Do you say vascular dementia?
Vascular, yes.
Okay.
Yes.
Interesting.
And
Okay.
that just okay. There's vascular. There's something also called Lewy body.
Okay.
Something called frontotemporal dementia.
Okay.
And I mean, that's kind of like the most common ones. But then again, it's kind of like the dementia diagnosis is like what's causing this sort of deficit. What's this person having like issues with their memory, and then when it advances, like their functioning overall. And so yeah, there's sort of kind of different types. They kind of have the different kind of like physiology or like causes for each type of dementia. For example, for Alzheimer's, it's believed to have it's caused by building up of proteins in the brain, specific proteins. We call tau protein, amyloid protein. But like that's kind of the specific sort of thing that they're looking for. But with the different type of dementia, you think about like the onset of the issue, like and what characteristics the patient has. If it's like a progressive sort of loss of memory or issues with memory, you can usually think about Alzheimer's. And like let's have, for example, like vascular dementia is very common with people with vascular problems, which means like issues with like the blood vessels, like people with high cholesterol, diabetes, people who have strokes that sort of
Loss of oxygen type of a dementia that.
yeah, exactly. So
Okay.
yeah, so when you have like what we call insults to the brain, that definitely has to affect the functioning.
Right.
And then the way that this dementia is kind of like presenting itself is like a stepwise process. Like each time it becomes a little worse.
Right.
But it's based mostly because of the of brain issues, blood vessel issues, like heart, issues with artery disease, right? And then, like, for example, Lewy body dementia, I mean, each one has its own little characteristics, but this one has, there's hallucinations early on with this type of dementia. And also, like, what we call Parkinsonism symptoms similar to somebody that would have Parkinson disorder. And, like, for frontotemporal, like, it's at a younger onset, and then usually related to also some sort of protein buildup in the brain. But yeah. So we have some kind of like categories to kind of like based on the symptom presentation, on the onset, on the progression of the disease, and kind of like in certain characteristics. But of all the dementia types that we look at, the Alzheimer's is kind of like the one that's most prevalent in our population.
So I feel like with Alzheimer's, there's been so many leaps and bounds with the research in the last decade. I said the last 20 years or so, but over the last decades. And we've been doing this show now for 27 years. And I remember when we were doing a program on dementia, and specifically on Alzheimer's, way back in the beginning. I remember one of the doctors saying that it was so hard to diagnose true Alzheimer's, because a lot of times when someone passes away, then you can afterwards go into the brain and find all the proteins that were there. I would love to take us from that time, Dr. Aguirre, to now of how we in our society are starting to diagnose different types of dementia, different types of loss of brain that you said, but memory issues. Again, there's Alzheimer's, there's a lot of the ones that we were talking about. But in general, how is the diagnosis done? And if we can take a couple of steps backwards too, we all kind of joke about, oh, I'm having a senior moment, or you're going through menopause, oh, I'm having a menopause moment, or I'm just stressed out, or I'm having a stressed out moment. So how do you differentiate the casual, man, I can't find my phone, where's my phone? Does anybody know where my phone is? To true stages of when somebody should be worried.
Right. And so right before I get into that, I wanted to clarify one thing. So I've had family members come in before and say, oh, she has dementia, but she doesn't have Alzheimer's. And so I want to clarify that dementia is an umbrella term. As Dr. Enriquez already elucidated, we have different types of dementia. So Alzheimer's disease, Lewy body, vascular, frontotemporal, they're all types of dementia. Dementia is just the umbrella term. And really to figure out what the best treatment for the patient is really figuring out what type of dementia you have.
Okay.
Because the treatment may vary a bit depending on which one. And then another interesting tidbit, the frontotemporal dementia, which it tends to be of a younger onset, in the news a lot lately. Bruce Willis, that's the type of the
Gotcha.
type of dementia he has.
Okay.
So I guess if you always want to remember what type of dementia hits younger patients, that one does come to
No, that
mind.
helps because you'll hear about it here and there.
And-
And when it hits you, it's like, okay, that's the one.
And of course, a lot of people think too, Michael J. Fobbs, we know he's been dealing with Parkinson's for a very long time, and Parkinson's related dementia is also within that category. There's also a whole subset of dementias that don't really fall into those categories, and that's because they're secondary to psychiatric illness or end stage of certain psychiatric illnesses, such as schizophrenia. There's also from alcohol-induced or drug-induced, from long-term drug abuse or alcohol abuse, and that we know that can end ultimately in dementia as well. And so the treatment for dementia, it always gets so casually thrown around.
Well, let's talk
And
about the diagnosis.
I think that's really where someone who's specialized in diagnosis, such as a geriatrician, a neurologist, or a psychiatrist, really is important, because these are the type of complaints that we get on a day-to-day basis of, I'm forgetting my phone every day, so I must have dementia. And you can't just say, oh, here's a pill, this will make your memory better. Like, we really need to figure out, is this memory loss within the normal realm, or is it not? And so the old way, which is still the current way for most doctors of doing dementia, is number one, looking for reversible causes of memory loss.
Reversible cause.
So reversible causes include like severe anemia, uncontrolled diabetes, vitamin deficiencies, such as vitamin B12 or folic acid deficiencies. And then, of course, having brain tumors, prior strokes, underlying arrhythmias that lead to strokes, cardiovascular heart disease that's affecting blood perfusion to the brain. And so we have to really do a comprehensive evaluation of what could be causing these changes in memory of the persons. There's even pseudodementia. So pseudodementia is someone who presents as a classic dementia, but then in reality, there's some type of uncontrolled mood disorder, depression, anxiety, other psychiatric illness that's not well controlled. And once the patient is placed on adequate treatment for these type of issues, then the memory actually goes back to normal. And so pseudodementia also categorizes into that reversible causes of dementia.
Okay.
And so in my practice, and it kind of mirrors the practice that we've had for a while now, first we look for the reversible causes. We run blood tests. The blood test that we typically would run would be a complete blood count, looking for that anemia, a vitamin B12 level, a folic acid level, a thyroid stimulating hormone level, because uncontrolled thyroid disease can also cause it. And then we would do a brain MRI. And then we would do some type of memory screening test. The most widely used one is one that's called the mini-cog. It has you remember 3 words, draw a clock, and then they tell you what time should be on the clock, and you have to put it.
I would qualify for an insurance, and I had to take this test. I was like, this is me nuts. And I felt like a knucklehead.
During residency and fellowship, I told people, you are aware that we're going to have to come up with a new screening, because people don't look at watches anymore.
Right.
Everybody looks at their phone and they look at digital. And even in day-to-day practice, I could say that is the truth. Even if my oldest olds, even my 90-year-olds don't look at clocks anymore. They look at digital things on their wall, maybe a big digital clock with big numbers, or their phones as well. So more and more, I'm getting a lot more false positives that they test positive for potential cognitive impairment, but it's just that they don't look at clocks anymore. Once we see if there's something reversible or not, if, let's say, your thyroid's not well controlled, let's say you do have depression or anxiety, then what we try to do is we try to correct those abnormalities first, or at least I do, before even moving on to the next test. Because I know the probability of you failing that extended testing that we do just goes up. So I'd rather correct as much as I can, so that not just the patient, but also the families feel like it wasn't a rushed diagnosis.
Right. I'm going to ask something really quick. I'm going to interject thyroid issues because as people get older, that's when the thyroid starts going a little bit crazy. I am hypothyroid, have been since I was pregnant with my daughter at the age of 30. But when the thyroid, I would like just to take a moment of what the thyroid controls in this area of memory. Obviously, there's, my gosh, what am I looking for? Energy, a little bit of energy, weight gain, weight loss. But in general, the thyroid, I think that it's an underrated issue unless you know about the thyroid. Does that make sense?
So you're right. Like typically under the age of 60, we wouldn't really screen anybody for thyroid issues unless they were having some type of symptoms. Once you're over the age of 60, I think we do try and screen everybody at least once a year to make sure that there are no thyroid issues, because we know it is involved in a lot of metabolic processes in the body. And so the symptoms that are involved with the thyroid is so wide ranging.
I know, that's the
From
thing.
loss of memory or feeling like you're sluggish to feeling like you're anxious with palpitations to weight gain to weight loss, depending on what spectrum of hypo or hyperthyroid that you're on. You're constipated, you're not constipated. Proximal muscle weakness, not being able to get up from your chair or even raise your arms above your head. The thyroid has a lot of implications throughout the body, not just the memory, but certainly in the memory, it's something that we look for in the memory assessment.
Well, I'm glad you talked about that because I feel like that's something we never talk about. And since you brought it up, I thought that was a perfect thing to do. So as you're talking about diagnosis, unless you had something to add to that.
Yes,
perfect.
Yeah, so that was
okay.
That's really just like the initial. That's day one. We show up. We take a comprehensive history from you. Is it your short-term memory that's affected? Is it your long-term memory? Is it affected? Do you feel like you get more confused as the day goes on and the evening hours approach? Are you anxious? Are you depressed? We do include a depression and anxiety screening as part of your memory assessment. Are you having any psychosis? And that can mean, are you hallucinating? Are you hearing things? Are you seeing things? Are you in danger of hurting yourself or hurting others? Are you wandering away from the house? Did grandpa or mom or dad get on a bus and end up in another city at some point? And it happens all the time. And one gentleman that the second he got the keys, he was heading over to Mexico, just like he did when he was young. And so the family was always worried that where did he go to Mexico? And so a lot of this is the wandering is a big one. And that's the one that really sets off families. They can disappear for days at a time. And when they come back home, it's usually escorted by a police officer, or in the case of one gentleman that I took care of recently, the Mexican police called them and say, please pick up your loved one.
Oh my goodness.
He's been living on the streets in Juarez, completely lost.
And they found ID on him, thank goodness.
Thank goodness they found an ID and they were able to contact him, but he was living homeless on the streets of Juarez doing God knows what because his memory wasn't working the right way.
Right.
And so this history is important to see, okay, does this sound more like a psychiatric illness? Does it sound like maybe potentially, yes, memory loss? But before we can say someone has dementia, we have to do the screening and the reversible workup to make sure there's nothing that we can actually correct. So many people show up with a dementia diagnosis and they end up not having dementia. It's something completely different.
And that's the part that interests me. And so I'm going to go with Dr. Enriquez for a moment and ask about risk factors, if there are any that you can tell, and if there are some that you can tell prior to being 30 or 40 or 50 years old. I'm not sure if there are, but in general, when people ask you for risk factors, or my mother, really had an issue with dementia, am I going to have that? Maybe she had Alzheimer's, maybe she had Parkinson's, maybe she had, as you were talking about, Lewy body, which I don't know yet what that is. Vascular dementia makes perfect sense to me. Anytime you have some blood constriction or oxygen constriction to the brain. Frontal temporal, I can see that being younger. Like my son who's 22 keeps saying, Mom, all the mistakes I make, it's okay because I'm not frontally temporally developed until I'm 25.
My frontal brain is fine.
Yeah, exactly. It's just
Not developed. Yeah, right. Yeah, right. He has an excuse.
It's an excuse. But in general, what could be risk factors? I know that you were kind of covering some of that in there, but when somebody comes to you, family members come to you and ask you what risk factors there are, what are your answers to that?
I mean, first of all, Lewy body, real quick. So like,
So that was the one I didn't get. Sure.
it's by some sort of a genetic issue, your body starts building this protein inside the cells, right?
Okay.
This kind of like messes up with the cell function in your brain, and sort of like it causes these symptoms under pressure, like which include that person has to start having hallucinations and then eventually having memory issues. And as well, like it has effects on their like mobility. They start having like I said, Parkinson's symptoms. But it's usually like a disease or some factor, some genetic thing that causes this protein called alpha-synuclein. That's the scientific name, I guess.
Like a doctor now.
It's just the scary protein that is making a mess in the brain, right? It's kind of like altering the function of the brain, and it identifies with some sort of like clinical presentation. It's actually being like more common than before. It's kind of like a more relevant thing regarding like the dementia umbrella, right? Okay. So going like to the risk factors, genetics is one of the main ones, like having family history of somebody having some sort of dementia, cognitive thing in your family in the past, right? Age is a very big factor, especially for Alzheimer's, because the starting at 65, I think like the percentages, if Dr. Aguirre can correct me, like it's kind of at 8% of the population of within like 65 has some sort of like
8%? That's
Yeah.
a pretty big percent.
very big. And once you get to like the 80s, it kind of goes to the 40%. So like, so it's like the age is kind of like, I mean,
And that makes sense.
and then like the processes of like, this genetics having some sort of protein alteration in your brain starts very early. We still haven't kind of like figured out like the best way to identify it. So we know how to identify like specific genes for like maybe you might be at risk of having like Alzheimer's, but it's not really like you're gonna have it, but you're at high risk, right? But like the risk factors go age, genetics, right? Trauma to your head. People like that have incidents, traumatic brain injuries might be at higher risk of having of dementia, having cognitive issues later in life. Like Dr. Aguirre was mentioning, alcohol, drug use also, affects the brain functioning, which could have effects in the future. And I use also like, taking care of your diabetes and hypertension with your patients, right? Yeah, because in the past, you have diabetes, hypertension, cholesterol problems, you're gonna get a stroke, you're gonna get a heart attack. But now I also use, if you have the genetic makeup, you might be also like speeding up for some sort of dementia, right? So having uncontrolled diabetes, uncontrolled hypertension, not taking care of your cholesterol might also affect the risk. Like you're affecting the vessels in your body, the vessels in your brain, so the blood flows, that's important. And over time, it's been shown that like this can cause the protein buildup as well. I was also like looking at some stuff like lack of social interaction, like loneliness.
That's talked about quite a bit.
Yeah, about
And geriatrics in general, loneliness.
exactly.
Is a bigger issue.
So you already have the genetic predisposition, and you have some sort of problem with loneliness. You're isolated from like socially, or you don't have those connections. That might also be a risk factor for you to develop dementia or speed up the process, right? And it's kind of sort of those things that kind of like have the sort of the risk factors, not doing exercise, not eating healthy, and like the cognition too, like not stimulating your brain, like. And then I think I was doing like the cognition training, which means like learning new stuff. Like unfortunately, that degree of education is also one of the risk factors that's considered, because apparently the more education that you might have, kind of like the less of a factor. But and like the genetic sort of makeup is kind of like the baseline, right? Yeah. And then all these factors can just like contribute to it, accelerate it, and we just have to be mindful of those, and kind of like that's what we try to do, right? Change the things that we can while we're trying to determine or kind of like figure out ways to detect it earlier, and even to, which we'll talk about treatment.
I heard a lot of things like, do puzzles, the wordles that are out there and this and that and the other, that all of that is good. Just try to.
And actually like learning things, like kind of like, exactly, like actually language or like a new process, right? Mm-hmm. Not like just simple memorizing, kind of like making your brain like process a little more, I think.
And I hate to be the bearer of bad news, but crossword puzzles or word finding puzzles are not going to stave off dementia. There's so many patients' families that should we buy them a crossword puzzle? Well, if they hate crossword puzzles, that's go and do that. It's like, what does your family member like to do? What do they like to learn? Do they like to bake? Okay, let's bake a cake. What do you need? Have them learn new things. Have them repeat them to you. Certainly, we're also learning more processed foods. Our Western diet doesn't do much to help us with staving off dementia either. If you've seen that documentary on the blue zones, some of these
I did. How fascinating.
some of these areas had certain types of foods,
was a big one on
certain
that.
types of foods that have antioxidants that also prevent the buildup of these beta tau and beta amyloid and tau proteins.
Yeah.
And so our diet is starting to become a big factor. There's lots of things that we still don't know that we're learning now that in these blue zones they're actually eating more of, and it seems to be beneficial to prevent the onset of dementia and the accumulation of these proteins. Sleep
Right.
has
Such an
also been
underrated
found.
thing, too.
It's still something that we do every day. We spend a third of our life doing, hopefully. So hopefully we're learning that to a certain degree while we're asleep, there are some brain processes where it's like you're sticking your brain in the dishwasher and it's cleaning out these proteins, these toxins that we're supposed to wash out. So if we're not sleeping, then we're not brushing out these things that are causing these proteins to accumulate. And so sleep has become a new area of interest where we're like, oh, well, maybe the people that don't sleep, they get more dementia. And so, yeah, we are seeing some evidence.
Here's
of that.
the difficult question on that. I'm not a good sleeper.
Never mind.
Never
Like it's
have ever been in
You
a
sleep? What are you talking about? Yes, I don't even know.
Oh my goodness. I know it's one of those things, but and I think that for the most part, it's understood that sleep is good for you. And I'm saying this too in connection with anxiety, depression, some of the things that you were talking about that manifests in different ways of presenting, right? So those with anxiety and depression have more and more sleep issues. Sometimes they can get to sleep, can't stay asleep, or sleep for a couple of hours, not. Oh, this is a tough question. When does the role of medication come in for sleeping? I know there's the whole sleep hygiene situation. You go through your routine. I feel like I've done.
We could spend an entire show just working on
Sleep
that.
medicine.
At the end of the day, just as like a brief answer to that, if you look at the American Association of Sleep Medicine guidelines, like none of them are effective. And none of them are recommended. And none of them are recommended if you do use them for long-term use. No good answers to how we can help people get better sleep in terms of from medications.
So again, you're looking at the routine and hopefully sleep hygiene. On that note,
there's
you
a
have
lot
to
of-
add to that? Sure.
Yeah, like so there's a lot of things that people like could do, and like it's the simple fact of it's sleep hygiene. It might be just like kind of like not overrated, but like repeated so many times. But like even having like the phone like next to your bed or having television, like a lot of people don't think that it matters.
Lights.
Yeah, and like even like the temperature of the room, like there's a lot of little things that are very, very helpful. Saying like a schedule, trying to sleep a little later if possible, or like having some sort of like a routine, right? But yeah, like the medications might not be always the best answer. So I always try to encourage like please.
So touching on that,
Yeah.
I mean, the best thing you can do is really follow your own schedule.
Exactly.
Which unfortunately, the way we're dictated 8 to 5,
Yeah.
I got to go sleep now because then I'm not going to wake up for work.
Yeah.
But the best thing would be if you could follow your natural circadian rhythm, your natural sleep cycle. Not everybody wants to go to sleep at 9 p.m. Some people may prefer to go to sleep at 12 and wake up at 9.
That sounds like me right there.
Yeah, me too. But that doesn't really fit with our societal norms and our regular business hours, right?
Yeah.
So I think that's maybe a major contributor. And of course, in modern times, we have all these lights that tell our brain that it's daytime and we're awake, and that constant stimulation also.
The fact that you wake up, go outside, and just not stare at the sun, but kind of stare at the sun. Try to get that circadian rhythm into whatever your clock is.
Yes.
And I just naturally for the most part, wake up with the sun, no matter what time I go to bed. Good or bad, I don't know. But I just can't stay asleep at night. So I would like to touch base a little bit because, again, in the older population, and to your point, so poignant, social connection, sleep, movement, depression, loneliness. So when we're looking at all this as points of dementia, and it all makes sense, right? It's the health of the brain and how you get that going. Is there also a way to diagnose within the population? And let's say 65, but I feel like that's so young, like 75, 85. How does one diagnose depression? I mean, that sometimes is very clinical. It's a kind of a clinical, it's not like you can, get a blood test and say, oh, you're depressed. How do you deal with that? And then in combination with dealing with treating dementia. And I know it's a two-tiered thing, and feel free to both kind of take that. But Dr. Aguirre, we'll start with you.
We have validated surveys that help us determine who may have issues with depression and anxiety.
Okay.
One of them is called the PHQ-9, which we tend to use in younger patients. And then once you're over 65, we tend to use a screening tool that's called the Geriatric Depression Screening, the GDS.
Okay.
And then for anxiety, for both populations, we tend to use one that's called the GAD-7.
And these are Q&A type tests.
We are Q&A. They kind of ask you, do you feel like you're sad or down? And then you say never, rarely, sometimes, more than half of the week, almost every day. And so we have cutoffs for that. And then once we have that, of course, the next question is to ask the patient, well, you answered in this way. We think you might be having some issues with depression. What do you think? And usually some people will be like, oh, no, I'm fine. Are you sure? Because you answered.
That's the way they've always been.
Answered
They
this
don't
way.
know any different.
Well, some of them truly might have not really understood the question. Or maybe there's something that happened recently that has them feeling that way, but it hasn't really been anything persistent. But many times when it is positive, they'll start crying or they'll start sharing why they're sad. And then we can make a determination, unfortunately subjectively, of whether this patient truly is having issues with depression and anxiety. And then there comes a discussion of what do we want to do about it? Do we want to try medication? Because there are medications that we can use and we can use safely in the geriatric population. Very different from the ones that we might use in a younger patient to help them with these symptoms. And then, of course, counseling services, support groups, maybe enrolling them in an adult daycare where they have more of that social interaction and activities to stave off that loneliness that they're feeling.
So if I'm understanding right, this is all something that in your discipline at UMC you all help out with.
Absolutely.
So that I'd like to talk about that for a minute. So people who may be listening or watching, it's like, okay, either I myself feel this way, my parents, my uncle, whatever. Talk a little bit about what you all provide as your specialty and what happens with UMC in the geriatric discipline.
Like regarding like depression, anxiety. So like we are both.
And social interaction, I think that right there is such a big thing. You go somewhere where there's other people.
Oh yeah, sure. Like I guess like our main sort of like support for that sort of like resources, we have like very competent social workers that have, knowledge of what's out there in that community. Sometimes like we go throughout like our work and there's areas that we don't really like, can grasp. I mean, there's a lot of people that might be knowledgeable with things that are out there in the community through experience. I think social workers are really good help in kind of like guiding the patient, especially the caregivers, which we'll probably talk about.
That's a big question right now in a moment. Yes.
Yes. That's like I guess one of the most vital parts in the treatment and management of dementia patients, right? And so, like we have behavioral health specialists as well. We have the tools to diagnose, and we also are trained to like start treatments and help people with whatever they might need regarding depression, social interaction, like Dr. Aguirre was saying, like kind of like being aware of the adult centers that are out there for patients, and then social workers are lifesavers in my experience, and they can give us, both the family and us as providers, like a lot of the resources that might be needed to help these patients get started. Sometimes they don't even know these things exist.
Right.
And by the time, like when we go to a social worker, okay, these are your options, and we can start like getting the ball rolling and kind of seeing what's out there and available. And regarding like the depression part, sometimes like when you have like dementia patients, sort of like that might not be able to kind of like go through the questionnaire, right? So this is where like very important to like rely on those caregivers because they might change some like behavior change, like they're not doing the things that they're
They may
doing.
not be aware themselves.
Exactly, yeah. Or like maybe with the question they're a little more altered, their like behavior's a little more different than what previously it was. So that's kind of like also sort of like signs that we can see as providers. Because you mentioned we have to be creative, right? Because a lot of times we are not able to, because the patient is not able to kind of like give you that information.
Right.
So that's what's a good aspect. You have that kind of contact with the caregiver. And like going back to what UMC has, like there's plenty of competent people and like social workers, behavioral health people, providers that are like very knowledgeable of resources that we can have for the families and help them with that.
And
I
so,
love-
shortly,
yes, go ahead.
and so shortly before Dr. Enriquez joined us, so we talked a little bit before the show about how UMC is trying to improve and expand upon their geriatric services. Part of that is the creation of a formal geriatric service department for the outpatient clinics. Dr. Ismael Rodriguez, which isn't here with us today, myself and Dr. Enriquez are the beginnings of that. And so part of that creation came the certification of our outpatient clinics as geriatric friendly clinics. This is a national certification where we have to show that we're implementing the 4 M's of geriatric medicine. The 4 M's are mind, which is what we're discussing today,
Right.
mobility, medications, and what matters most. And so part of that integration of that into our clinics is we have to implement assessments, evaluations, and next steps to help our geriatric population in those specific segments of their lives. So in the mind aspect, certainly depression and anxiety screenings are a must for every new patient.
Oh, good.
On every visit, every patient is briefly screened with 2 questions, the PHQ-2, to see if they might have an issue with depression or anxiety during that day, and the GAD-2. And if they are, then they are given a full screening. And then also on their annual exams, we do the screenings as well. So depression and anxiety, something that we are very aware of, something that we do have a lot in our geriatric population, and something that we're constantly screening for. We talked about like part 1 of my diagnosis. We didn't get to the part 2.
Oh, this needs to be a 3-hour
But
long program.
in the part 1, the mini-cog, that first screening, that is part of your annual exam, and it is part of everybody's first visit with us in the geriatrics department. And of course, if the family or the patient, even if it's not within our typical schedule, if there is a concern about memory loss, then you're going to be screened automatically for cognitive impairment.
So here's a question to either one of you. So I'm thinking to myself, if you're of 65, 7 years of age, if you don't have, to your point, a caregiver, someone who is with you, a family member, et cetera, and you simply don't know that you're having these issues going forward, what you see in your practice, do you see that a very large percentage, and I'm thinking like 85, 90%, are the caregivers bringing their elderly friends, family members over? Are the elderly coming on their own? Is it a mixture of the two? Explain how you guys usually see that.
I think this may actually vary depending on what side of the city you are.
Yeah.
Interesting.
And I would say in the West Clinic, I would say probably of our elderly above age 65, probably the older they are, probably above 80, maybe 70% of them come with a caretaker, maybe as high as 75%.
And a
if they're
caretaker is somebody hired usually?
It could be a provider that they're getting through Medicaid.
Okay.
It could be a family member, or sometimes it could be even an extended family member, like a niece,
Okay.
or a friend. And I've even seen friends of the family that bring in people with concerns for memory loss.
Okay.
And then on our younger geriatric population, 65 to 80, probably 40% of them come with a caregiver.
So they'll go on their own and say, I'm having some kind of issue. I need to go check this out. Okay. That's wonderful here. Yeah.
We've had a couple visits where we've gotten to know them better, and we see a repeated stories, repeated complaints, maybe diagnostic tests that we ordered weren't done, medications that we ordered are not aware of. So then we start seeing the pattern that, you know what, maybe are you okay if we call your son, your daughter, your husband, your wife to come with you on the next appointment?
Okay.
Just so that we can verify what we're seeing and maybe get to that next step of figuring out what's going wrong with the memory.
Makes sense. So let's move over to, and I know this is like, oh my goodness, it's almost a can of worms. This is treatment now, right? There are so many different treatments, and understandably, the types of dementia we were talking about have obviously different treatments. So let's first talk about vascular dementia. I can see a lot of that is getting the vascular issues under control.
True.
Lewy body, sometimes that is, like you said, it is something that you can't, it's inherited, so to speak. So that's a whole different, something that may not be something to, share on the show for the next 4 or 5 minutes because it's too big to go into. Frontal temporal, same thing. But in general, not that there is just like the geriatric depression, anxiety, dementia, but let's pretend that there is that. What are some of the common treatments that you all do with geriatric dementia? I know it's loaded, I get it, but you know where I'm going with on this. Dr. Enriquez, would you like to start with that?
So yes, so I guess we have to be kind of like clear on the sort of like what
Diagnosis.
knows about like on what the treatment entails. And at this moment, there's no like definitive treatment, like a curative treatment for dementia. And like what the options that we have are usually to kind of like slow the progression of the disease, because there are many like patients that kind of like go and they're like, well, okay, we're having these problems with dementia. What's the medication that we are going to use to kind of like get rid of it or help our family member go to baseline to back? And like, unfortunately, the case is that of the options that we have, most of them just kind of like help kind of like with the progression. But at this point, it's something.
It's not like there's a magic pill.
Exactly. Like the disease will most likely progress to whatever it has to progress. And we have a couple of options that can help us sort of slow that progression. And they have been tested more specifically for Alzheimer's disease with people with mild to moderate, like cognitive, like memory issues. We have, they're called cholinesterase inhibitors. And we have 3 medications that are kind of like the to go to based on the experience and the research.
And these are medications that help slow down the progression? Is
Exactly.
I'm understanding that correctly? Okay.
Help. Sometimes they might be successful. Sometimes they might not. And one's called donepezil, galantamine, and rivastigmine.
Okay.
And then we have also what we call NMDA antagonists, and it's a drug called memantine. So we kind of recommend this when you have like a moderate sort of Alzheimer's disease. It might be helpful also with Lewy body kind of like issues with memory, but it's very limited what they can do. And it's also like having a conversation with the family that, you know what, it might work, it might not. Most likely, it might not have a significant effect. And you have to take into account that these medications might have significant side effects, especially like GI side effects, nausea, vomiting, diarrhea. So you have to kind of like put it in a balance, like and then you have to reassess after you start these medications 3 to 6 months after you start them. Like progressively, you increase them, right? But you have to kind of like pros and cons, right? If this medication, you've seen that it's not helping at all, the memory deficits are getting worse, and then just the symptoms are not tolerable, then it's not worth continuing the medication. But if you see that it has some sort of like effect, some sort of like benefit, at least you're noticing that there's some stalling in the progression of the disease, then it's fair to continue, right? And it's kind of like, I mean, it would be hard for me, like personally, my father has Alzheimer's, and I understand, like, I wish he would go back to the way he was. I wish that the medications were like a magic pill. But you have to understand, and we have to counsel and explain to our patients that it's a hit or miss. But it's also all has to do with the progression, because unfortunately, it's not something curative at this point. So that's kind of like the main to go. There's like people are researching, trying to come up with new things. And Dr. Aguirre and he was like enlightening me about like monoclonal antibodies, and I'll let him explain that. There's like new sort of medications, again, that might be helpful or not. Everything carries like a risk and benefit, but Dr. Aguirre.
Yeah, I was going to say at this point in the program, because we got a whopping 7 minutes left, but this is usually where I think, okay, this is what we have now. What do you see in the next 5-ish years?
Okay. And I just wanted to go to, so the medications that Dr. Enriquez mentioned, they are the ones that we typically do use. Honestly, from the research that I've seen, I don't think it actually, it doesn't really slow down the progression at all. I think the way I explain it to families is you're still going to get from point A to point B regardless. If your memory is going to go in 1, 5, or 10 years, it's going to happen with or without the medication. But you have to land that plane somehow. So it could either be a crash landing, turbulent landing for everybody, or it can be kind of smoothed out.
And like
where it's not.
I had a reference, like keep talking about when attending stuff, that she used to say like, you're going 80 miles per hour, but this medication should probably just bring you down to 70 miles per hour.
Right.
But it's still gonna go like it's still gonna progress.
And so we know most patients do better when they're at home in their environment, with their surroundings, with their belongings, with their family, with their sights, with their sounds. And the moment you take them out and you put them into a foster home or nursing home, everybody is shocked with how fast it starts getting worse. So that the intention with the medications is, if we see that there might be some benefit, if there are a lot of behavioral issues associated with the dementia, the better that we can smooth that right out for everybody, the better that the patient is going to do in their home environment. The newer medications, I think everybody tends to oversell them at this point. We're not sure. The monoclonal antibodies, they're the newest, greatest thing in the last few years. There are now a couple of them that have been released officially on the market. They are showing promise of slowing down the progression of dementia, 25 to 30%.
Oh my, that's a big percentage.
However, and here's a big caveat. Here's a big caveat. So we talked about the accumulation of beta tau and the amyloid protein, and they're very, very effective at removing up to 95% of these plaques in the brain in before and after imaging. And so what we're wondering now, does that mean, does their memory stay in the place where they are right now? Is that what we're talking about? Like, it's not going to get worse?
Yeah, it's not like regeneration of the brain
Or are we
cells.
talking about, suddenly we removed the protein, you're going to go 25% better than where you were before?
Right.
We're not sure.
Yeah.
We're not sure. And then in initial trials, the side effects were not benign. There were significant amounts of anywhere varying from 10 to 15% of brain edema, so swelling in the brain, and maybe some degree of brain hemorrhages, small brain hemorrhages. So as we get to use these on more people, are we going to see more of this? Is it going to be so bad that we're going to have to take the medications off the market? Or are they not going to be so bad, and are we going to see the benefits that we're all hoping that we're going to get? We don't know.
Right.
The point is, in El Paso, I don't know of anybody who's actually giving this type of treatment. I've referred a couple patients already to outside neurologic centers, but really the cost is prohibitive. I think a lot of the insurance companies are not willing to approve it because of the cost. 1 year treatment is about $26,000. This is from data that that I was privy to last year.
And this has been around for how long? 5-ish years?
Well, when they started with the development, and we started talking more about it. But as of like on the market, let's start giving people to it really last year.
Oh, wow. So this is brand new.
It is brand new.
Okay,
The
so we
VA
could have a complete different discussion next year. We'll really have
The
to.
VA last year approved it for widespread use within the VA.
Okay.
So I think we will get more data from them because
Right.
they don't have that limitations of insurance approval or patients' ability to purchase these types of medications. And hopefully from there we get more. If we get good results, then the insurances will start hopping on and approving these medications as well.
Right.
But I just want to give this big caveat. It is not curative, like Dr. Enriquez said. We're hoping on these monoclonal antibodies that it reduces the progression. For the current medications that we use on a day-to-day practice, I don't see any improvement in the progression. On the tests that we do, most of them are on a 30-point scale. It improves your testing score by 2 to 4 points.
Oh, wow. And I want to give out a huge shout out to caregivers. I know we talked a little bit about that earlier, but with dementia, that is so vital. And especially those that, family members, sometimes extended family. And it's just, thank goodness we live in a community where there are a lot of really good people. And so shout out there. I know we're running out of time. So I do want to say once again, thank you so much to Dr. Aguirre and Dr. Enriquez. Both of you are geriatricians with the University Medical Center, that's just with the geriatrics department. But thank you again so much for being here. Thank you to UMC, and appreciate you all listening and watching. I'm Catherine Berg, and this has been the El Paso Physician. Hello, I'm Catherine Berg. Today we'd like to pay tribute to a man to whom this very program would not exist if it weren't for him. A great man of visionary inspiration and a masterful doctor who helped take away the pain for so many people as a rheumatologist. He was a true advocate of public service and of education. Dr. Raj Marwa passed away unexpectedly on November 27th. The physician members and the officers and staff of the El Paso County Medical Society expressed their sincere condolences to Dr. Marwa's family, and also would like to pay homage to him for his dedication and service, not only to the El Paso County Medical Society, but to the community as a whole. He was a true Renaissance man. His duty to his community and his patients was his life's work. This program, the El Paso Physician, was the brainchild of Dr. Marwa. He, along with the executive committee of the El Paso County Medical Society, planted the seeds, watered and fertilized this production, and watched it grow into an award-winning medical education program. It is the only running program that has been going for 27 years in this entire country, and we have not been able to find in the world a long-running program such as this. Thank you again, Dr. Marwa. For 27 years now, it airs every single month on PBS El Paso, and in recent years, it's been available nationally and internationally through various online platforms. You can always find episodes on the El Paso County Medical Society website, PBS El Paso, and on YouTube. And again, it's the only running program of this type anywhere that you can find for the amount of time that it's been going. Each year, Dr. Marwa would host a thank you gathering for everyone that was involved in this production of the El Paso Physician. Just 2 weeks ago, Dr. Marwa addressed all of us in his humble way and with his quiet yet strong voice. And as usual, he was giving credit to everyone in the room and not even thanking himself, nor would he. It's not like what he would do. One of the doctors in the room could not have said it any better when he said, "Dr. Marwa, it is on the shoulders of giants that we stand." So true. Dr. Marwa, thank you from everyone who is involved with the production of this program. And thank you from all the people in the community who may have learned just a little bit something by watching this program. None of this would be possible without you. Farewell, dear friend.